Today's topic is herniated discs, and we are going to look at some very cool images. I found them to be super interesting, like extremely zoomed in, detailed images of vertebral discs. And so we're going to be able to look at all the anatomy and an incredibly detailed view and zoom in on what's going on with the discs and the nerves, and when a disc actually bulges and herniates, what happens to how is that impacting the nerve. We're going to be able to see where the disc pushes on the nerve and talk about the differences between the different kinds of nerve impingement. There are two major types of nerve impingement with the herniated disc. One is a sensory nerve that gets impinged or pressed on by the disc, and that's where you feel symptoms of pain or tingling, numbness. Could be heat, could be cold, burning sensation, electrical, pins and needles, you name it. The nerve can actually feel anything. It could make you feel anything, and it's pretty incredible the wide range of symptoms that you can get from is something pressing on a nerve. So there's not really a whole lot of limits on what you can feel from a sensory nerve impingement. Now, the other major type of nerve impingement is a motor nerve impingement. And this is not where you feel symptoms, it's where you experience what we call signs. So signs are things like weakness or even paralysis. And there are other types of signs in the body, but with a motor nerve impingement, those are really the two types. So it would be decreased strength or complete inability to use a muscle, which would be paralysis. And so that's a much more serious type of nerve impingement. And we're going to look at the difference between the sensory nerves and the motor nerves, where they are, and how a disc could possibly press on them. So looks like we got a good number of people here. So I'm going to get into the images now, not make you guys wait any longer. Let's see how we can do this. And just one more announcement. I have all of the chat questions from the previous stream link. If you were on the previous stream link that didn't end up working and you posted in the chat, I have the whole chat here, so I will be able to answer your question, and you don't need to ask the question again because I already have it. So let's get into the exciting part of today, which is imagery. So I can show the image like this, but I'd rather show the full image like this. So this is pretty cool. These are the images that I found on like a stock image site, and I had to purchase them because they were just so cool and so detailed. So let's talk about this stuff. So this is your disc, and you have the two parts of the disc. You have the annulus fibrosus, which is like very tough material, and then you have the nucleus, the like goo on the inside. So you can think about like a fig Newton. The nucleus is like the jelly inside the fig Newton, and the outside of the fig Newton would be the annulus fibrosus. A very tough collagen fibrous material, and it's really strong. It can take a lot of force and protects the integrity of the disc, of the shock absorption of the disc, which is the nucleus. So the disc sits on the vertebrae, which you can see here. You have some anatomy on the vertebrae. All of this bone that you see around the disc is anatomy of the vertebrae. And then you have the nerves and also blood vessels, which continue to, they go through the cavities and the foramen, as we call them, in the vertebrae. So the arteries and the veins are not visible in this image, but you can see the nerves. And I was talking about motor nerves and sensory nerves before, and so we're going to point them out. So when you see the nerves, they come out of the spinal cord here, and there are two areas where nerve roots, these are nerve roots, they exit the spinal cord. You have the anterior nerve roots, and these are the sensory nerve roots. These are all sensory nerves here, and they flow closer to the disc, and they join together with the motor nerves, which come out of the posterior side of the spinal cord, and then they form a actual full nerve, and this would be, at this point here, you would call this, like if this was L5, this would be the L5 nerve. Okay, so the significant thing about the anatomy here is that when you have a disc that herniates, for example, like this, or bulges, it's most likely going to press on the sensory nerves before it presses on the motor nerves. The motor nerves are more protected because they are behind the sensory nerves, and it would take a much larger, more significant herniation to press on the motor nerves. This is a really good thing because sensory nerves don't lead to paralysis, and they don't affect too much of the function in your life. You could have the sensory nerves get pressed on by a nerve, and they will cause symptoms. They will cause pain or tingling or numbness, but they are not going to cause a muscle to be paralyzed. And so that's one thing I just find really interesting by knowing the anatomy. It can actually, for me anyway, it gives me a sense of relief, a peace of mind that just because I have symptoms from a nerve compression does not mean I am going to get paralyzed. And so they are different nerves, and they come out of the spinal cord at completely different places. And so this is a much more common occurrence. And when you do have a sign of weakness in the muscle, or even paralysis, and the muscle is no longer functioning, that is a more serious situation where you would want to go in and see a doctor, get some imaging, and it's probably a situation where you might want to consider getting the herniation of the disc removed so that you can take the pressure off of that motor nerve. But with a sensory nerve compression, it's a little less serious, and the pain might be annoying, the pins and needles, the tingling, that whatever it is, it might be annoying, but it is not detrimental to your function. The only way that it really does affect your function is, if you stop using your body, stop participating in life because of the symptoms. Or potentially another way it could affect your function is if it causes numbness in a part of your body. And we do use sensation to, like in our feet, to walk properly and stuff like that. So if you do have numbness in your feet, then it may affect the way that your foot contacts and reacts to the ground, that ground reaction. So there is that factor for sensory nerves. So here's another image that I found that really details, you can really see the different parts of the disc, the annulus and the nucleus, and you can really see the spinal cord. So this is actually a specific level. This would be L5, and I know this because at the L5 level, the spinal cord starts separating into what they call the cauda equina, and it's where all the nerves start coming out of the bottom of the spinal cord separately, like a cauda equina means horse's tail. So you could imagine it starts looking like a horse's tail, and it's how the spinal cord ends. And so you can see the nerves coming off of them, and then you have this bundle here where there is a whole bunch of nerve endings coming together, and that is an area that tends to get pressed on by structures. Let's take a look at some more images of the vertebrae. This is another angle. We have the spinal cord that is behind the bone here, but you can really see how the nerve roots or the spinal nerves exit through the holes. So this would be a lateral foramen, this hole here. And you could call this potentially a L4 or L5 nerve that exits out of that foramen. And this would be how potentially a nerve could get compressed in a stenosis situation. So if this foramen gets closed down, this hole right here, this gap gets closed down by a decrease in space in the nerve. I could actually go split screen here. So if, say you get stuck in kind of a stenosis or backward bending position in your spine because of anterior pelvic tilt or muscle imbalances, and this part of the disc starts getting compressed, maybe it doesn't bulge out into the space, maybe it starts bulging more forward, but the space decreases and the nerve can get compressed by bone. So that's another way that you could experience similar symptoms like sciatica. And here is another image I found very interesting. This is an image of the joint that I'm now forgetting the name of. And you can see how the nerves, that when they come out of the foramen, there's just little branches that come off in all different places, and they're connecting with other nerves or going and innervating different parts of the anatomy. And so this is the facet joint that connects the vertebrae above. Say this was L4 vertebrae, and this is the spinous process, and it has a joint and called the facet, and that joins together with the L5 vertebrae. This is the spinous process of L5, and that's how they interconnect. Aside from the disc, this is the other spot where they interconnect, and this joint can get inflamed. It really does help hold the vertebrae from sliding on one another, like in a spondylolisthesis situation. So when you have like an injury, like a spondylolisthesis, this joint is preventing the slippage. But if there's so much force that it causes, say, a vertebrae to slide forward against the force of this joint, it actually can break. There would be a fracture right here where my mouse is going across, and that would be a spondylolysis, a pedicle fracture with a spondy. So we talked about spondy last week, and somebody asked about a fractured spondylolisthesis, and so that would be where it happens. All right, so let's keep going through. Here's an image of the front. So this is the anterior side. I've actually showed this image in the past, and you can just see how the spinal cord is starting to separate into that cauda equina. All those nerves kind of it starts looking like a horse's tail, where they start separating out, as opposed to this when the spinal cord is one solid cord. You can see the difference. The spinal cord is a bunch of like thick hairs, and this would be the L5 nerve coming around, and you can see that's the foramen there. Here's another image. Now this is another way that a nerve can get compressed, and this is not actually a herniation of the disc. This is bony growth, calcium buildup on the actual vertebrae, and that can build up so much that it does close down this foramen, this lateral foramen, closing down the space and pressing on a nerve. And so when people have symptoms of sciatica or, other, like the proper term is usually radiculopathy, so nerve referral symptoms in the legs, it's not necessarily from a herniated disc. And there are several different causes that it could be from. And it is beneficial at times to know what are the causes, but most of the time I would say that no matter what the cause is, whether it's bony growth or a disc herniation or stenosis, the solution is still going to be the same. It doesn't really change what you need to do in order to get out of the problem. You need to create more support for your spine so there's less compression and less pressure causing these problems. But what it does help to get, when it helps to get diagnosed with a really, really specific condition like this, is it would help a surgeon, if you were going to get surgery, to determine what type of surgery you were going to get. I think that's the most beneficial thing. I found this image to be extremely interesting, just kind of showing an image of kind of what it feels like to have those, a nerve compression. It can be very broad. It's not usually a very specific location, but it can be. But you can get just broad electrical type feelings in your buttocks, in your thighs, or down into the legs. And this is one more image that I found. This is what happens after you get a fusion surgery. And here we are. And so you can see that they actually put some bone in between the two vertebrae, and with the hardware, you wait until that bone actually literally fuses into the other bones before you can actually start doing more physical activities. So they want you to wait a good 4 to 6 months to allow this real actual fusion, bone fusion, to take place. It becomes one big bone. You got two vertebrae here, but they have now become one bone. And that takes time. So that's why it is really important, if one were to ever get a fusion, that you don't get into activity too early. And so you want to allow time for this fusion to take place. So with most other surgeries, you want to keep your muscles active and keep your support for your spine really strong, but particularly with a fusion, it may not be beneficial, and you may, there is a period of time where you allowing your body to get weaker while you let that bone fuse before you can start building up your muscle again. So I know this topic of the stream was supposed to be herniated discs, but I had all these images I wanted to show. This is really the main image of the herniated disc that I found to be extremely informative about what type of symptoms or signs or symptoms that you feel and why. And most likely it's going to be only sensory symptoms, and you're most likely not going to have signs of weakness or paralysis unless it's a really large herniation, like a massive herniation. So I'm going to go ahead and look into the chat and see if there's any questions. And if you are showing up kind of late, I was saying that if the old stream link chat I still have in front of me, so I have all the questions from the old stream link from earlier. So, but I'm going to go ahead and go to the new stream link chat because I know all these people are still here live, and we'll see if I can. I don't want to screw this up. just in case, I'm going to take a picture of the old chat. Okay. Now we'll get the new chat out here. All right. So we'll see if there's any questions about the stream, about on topic with the stream. All right, so we got, thank you, Sherry, for the feedback. Everything looks good and sounds better. Yeah, we changed a couple things in the room, so hopefully it does sound better. And Stian says, where do you live now? I still live in the same city of Santa Barbara. We just moved into a bigger home because we're living in a 1-bedroom, basically, apartment. And it was too small for our growing family. All right, Ray, being 64, it's a slower process. Retrolisthesis in L1 through L3. Is the program good for that? Absolutely. I personally have or had a retrolisthesis, and definitely the program was designed for me. I fit into the majority of the population of people with the predictable pattern of muscle imbalances that causes problems like this in the body. And yep, the program was designed for me, and it is very effective for something like a retrolisthesis. Ray, good question. With no pain in the back proper, only referred to glutes and hips, cramps, calves. Is that muscles or vertebrae? So one other thing that I didn't really mention is that if we were to look at some of these images, there are some images that are really interesting that can show this even better. But this one's a decent one. You can see how many nerves are flowing through the body. And actually, I'm going to go ahead and see if I can get this other image that's so interesting to me. This one's really interesting. Oops. Okay. So you can see how many nerves are flowing. Muscles that get inflamed or get, or even just any soft tissue that gets inflamed and maybe swells up a little bit can also press on one of these nerves. And so when we associate nerve symptoms with an actual diagnosis, even if you've had an MRI, even if you've had a doctor look at it and say, you have this disease in your back, we still can't really ever be sure exactly what's causing the nerve symptoms, because there are so many nerves. Even every single nerve, if you follow one nerve along, it could get compressed at any point during its journey down the leg. And so it could be a soft tissue. It could be, this was prompted by the question by Ray, who asked if it could be muscle. And let me go back to that question. The chat was right here. With no pain in the back, proper only referred to glutes, hips, cramps in the calves. Is that muscles or vertebrae? So we can't really know. It could be the muscles. It could be the vertebrae. It could be the disc. It could be bony growth. These are all things that could cause symptoms. And, if you were to try and get it diagnosed and figure it out, that may be helpful to a surgeon, as I was saying earlier, but it's most likely not going to be going to change what you need to do for your body, because all of these different diagnoses are symptoms of a spine that needs more support, that needs more muscular balance around it, that needs to be decompressed a little bit. We don't have problems from a spine that is too decompressed, right? The problems are from too much compression and too much pressure not enough support for the spine. So that's the goal. And luckily that is possible to do through things like your breath and developing muscular balance through a healthy core connection. All right, so keep going. So my spondy had natural fusion 1 through 3, and I have pain on my leg. So this is really interesting. We showed the image of the fusion, and this person, who I cannot pronounce that name because I don't read that language, says they had a natural fusion, which is another thing that can happen. So if a spondy occurs to where two vertebrae end up touching each other, say L4 and L5 just naturally start touching each other, those bones can fuse together naturally. The doctor, the surgeon doesn't need to stick a bone in there to fuse the spine. So that is actually a really great thing that the body does because it's a natural protective mechanism. Sometimes the body needs to fuse itself to develop stability, and it can do it naturally. So you can actually let yourself get a natural fusion without having to go through the surgery. So this is what happened here. I have pain in my leg, but not all the time. Usually at evening, pain is gone, but my MRI says the nerve is not pinched. What you see, doc? So everything I was talking about earlier is going to be relevant to you. And it could be any number of things, but at the same time, it really doesn't matter unless you're going to get surgery or unless you need to rule out like a soft tissue growth, like a tumor or something like that. That would be another situation where imaging is really beneficial because it can save people's lives if you can find something like that. But to get the diagnosis of like where the nerve is getting compressed, just for your mental knowledge is not going to really change the solution. And you said not at evening the pain is gone. That's a really interesting thing. That's kind of unique. So it may just be that the fluid in the disc in the evening there's less fluid in a disc in the evening time. So maybe the fluid in your disc causes enough pressure to press on the nerve, but by evening time there's not enough fluid in the disc to cause that pressure, and maybe it's no longer pressing on the nerve. Jen, what are the most injurious types of movements on an SI joint? I want to return to practicing open style dance, a mix of hip hop, urban, contemporary, jazz, and unique movements. Please explain. This is a really great question, Jen. So there is a video that I put out specifically about this, and I'm gonna just assume that you haven't seen it, Jen, because it's exactly answering the question with like visual demonstrations of all these movements. But I talk about the 5 different movements that you should avoid with an injured SI joint. I'll go over them real quick. So one of them would be, well, basically in a nutshell, it's all of the movements are extreme hip range of motion movements. So anytime you take your hip joint into a position of extreme range of motion. So that could be external rotation, that could be internal rotation, that could be flexion, that could be extension. What happens when you go to the full end range of motion, where you're feeling a stretch in the muscle? It's not only stretching the muscle, it's also stretching the other soft tissues around that joint. And any force that goes into the hip joint and is takes that hip joint to the extreme end range of motion is going to translate through the hip joint into the next joint as well, because you've locked that hip joint all the way into end range, and there's no more motion for it to move anymore. And so it goes to the next joint up, and the next joint up is the SI joint. It's the very next joint up from the hip. And so, with dancing in particular, you could do pretty much every type of dance besides ballet. You can do hip hop, you can do urban, you can do contemporary, jazz. You can do all that stuff without taking your hips to complete end range. And if you do go to end range, you want to make sure that it's an active movement. So the muscles around the joint are actively controlling that motion rather than like a passive stretch. So this is, it's a really good thing to know. So I would recommend, Jen, watching that video. It's called Stop Hurting Your SI Joint, and just knowing that, stretching your hip to end range is the type of movement that stresses the SI joint. The most shearing, harshest patterns of movement to avoid, i.e. single leg stomp or jump with the upper body bending sideways, seems to strain the SI joint. Those are kind of be some more unique movements that would be beneficial for you, just like you are already doing, to listen to your body and say, all right, that kind of hurt my SI joint. Like I felt it later that night. I clearly felt it doing that stomp motion. All right, maybe I'm going to avoid that or stomp a little less hard. But if you have good muscular contraction around the joint, you should be able to stomp. But if your SI joint's pretty aggravated, pretty irritated, then in that situation, you would want to avoid, any kind of impact movement. All right, Ms. Tran, wonder if the hip flexor is the culprit of SI joint. Does it mean that the centralizing will cause more pain in the hip flexor rather than the lower back? So this is a good question. I actually spoke about this a couple months ago, and in not this Thursday, but next Thursday, there's a YouTube video coming out specifically about this. So the SI joint is definitely impacted by a specific hip flexor called the iliacus muscle. And the iliacus muscle is a hip flexor that tends to get tight, just like the psoas, and it puts a lot of torque on the SI joint. So what is your question? The centralizing will cause more pain in the hip flexor rather than the lower back. Centralizing is a term, Ms. Tran, more relevant to nerve injury. And so if you have a nerve injury, it doesn't matter if it's coming from the low back or the hip flexor or the SI joint. It's going to behave very similarly, where if the injury is improving, you're going to have centralization of symptoms. And so hip flexor is the culprit most often, but that's just upstream of the next chain of events that happens. So hip flexor, then injury to the ligaments, most likely the posterior ligaments of the SI joint. And then from there, you experience pain. That's down the chain. And then potentially nerve compression and symptoms down the legs. But if you go upstream, you hit the hip flexor. And then if you go upstream of that, we're talking about posture and lifestyle and core connection and movement and how you relate to your body. So I see last question is pointed out here. I'm just going to read a little bit down below to see what people are saying based on, because I haven't read any comments related to herniated discs yet. So I'm just looking for stuff like that. Nikki says, thanks for showing. Indeed, very helpful to know. I used to have muscle weakness in my right leg in different intensities. I don't have that anymore. Good to understand that it's a good sign. Oh, yeah. So you had weakness in your right leg. So that would be an indication that a nerve was compressed and no longer is getting compressed. So it's obviously it's a fantastic sign. And what I would say to you, Nikki, is whatever you did or are doing to make that progress, I would triple down on that. Do so much more of that, because your body liked that, and that was a clear indication of that. Okay, so Karine is probably referring to this picture when she says that is exactly my pain. Yeah, it's a really great image to describe a feeling through a visual. I found that to be really interesting. Really appreciate the lessons. You're very welcome, Fuzzer. I appreciate your constant gratitude. I'm sure that really helps you in life. I got to be honest. Trevor, can massaging the lower back with a ball near the QL loosen things up? All right, so these are the questions that were posted after the last question comment, and I'm going to try to get to these towards the end, but I have a bunch of questions that were on the other chat. So here's to answer your question, Deborah K. Yes, I'm going to go to the other chat right now because there were a bunch of questions here, and I want to answer all of them because they were all made before the last question comment. So let's see. Looks like the first one is from Travis. And Travis says, I just wrapped up my first week in the program. I'm also 37. I'm actually 38 now, Travis. I turned another year and suffered the same injury as Ryan. I've seen surgeons, osteopaths, chiropractors, acupuncturists, physical therapists, and PTs. Let's see, sometimes people make another comment after that. This is the first time I've been fully described what is going on mechanically. So thankful. My question is on TENS units to keep the core muscles activated. Do you recommend? When I do work, I use a girdle type brace. Do you recommend? Should I ditch the chiro? Let me keep reading your comments, Travis. My main problem now is that my lower back muscles are so tight and knotted, it's hard to relax them and let loose. The program is working phenomenally for me as I've just been biking, running, and swimming through the pain. Now I know the McKenzie method was actually setting me back. Yeah, I mean, your body, you know, if it was helping you, your body would tell you. And if it was setting you back, you weren't getting better and you learn about what's actually going on with McKenzie, then it's very possible. It does happen. So those were all your comments. So let's answer them. I hope you're still here, Travis. I don't know if you are. I didn't see you in the new chat, but all right. The first question from Travis happens here. TENS units, I don't really think that they're important or necessary or even beneficial in the situation of activating muscles. There is a type of TENS unit that you can use, but I would much rather just use physical exercise and muscle activation through exercise. So I don't recommend a TENS unit. For some people that are in unbearable pain and don't want to take a whole bunch of pills, you can use a TENS unit to kind of scramble your pain nerves and sensory nerves for a few hours, and it'll work temporarily to reduce the pain. Not a big user or fan of TENS units, but it's not really causing any damage besides the fact that people think that they're doing something good for themselves, and that is a really huge concept that I want to talk about more. When people are doing something, thinking that they're doing something good for themselves, it is a waste of energy and resources that they could be using to actually be doing something good for themselves in place of that. So we'll talk more about that another time. Use your energy on and your focus on the most effective stuff. That's what I have to say. And the TENS unit is not that. When I do work, I use a girdle type brace. What I would recommend is a corset type brace, Travis. So you can find one of those at CVS or Walgreens or whatever, sporting goods store. And yeah, you can use that for work. And then when you exercise, be complementing that brace with exercise to develop that natural brace with your muscles. Do I recommend? Yeah, I mean, it can be really beneficial to use a corset type brace to prevent injury and help support your spine temporarily. Yeah. Should I ditch the chiro? Don't completely ditch the chiro if you've become dependent on the chiro over a long period of time. I would make it a goal to put more space between each chiropractic visit. So if you went every week, try to go every 10 days or every 2 weeks or every 3 weeks, and just gradually and progressively put more space between each visit. Wean yourself off, because people can become dependent on those regular adjustments. And I think those were all the questions from Travis. All right. So next is from Miss Tran. Wonder if the hip flexor, we already asked that. Okay. My pain recently changed to the hip flexor area, and interestingly, I can't cross legs now as I feel tightness and pain there. I could before the pain started to change. I do feel stronger overall. This is one of those things, that when pain moves into a different area, I see it as a good sign that you targeted the pain where the original source was, and pain often moves to a different location before it leaves the body. So keep doing what you're doing, Ms. Tran, and keep listening to your body. I see that as a good sign. The body, where are we at? The body is surely a mystery. I've been going very slowly with the modules, 3 weeks per module now. Yeah, I fully support that. Yeah. Personally, I would go even slower than that, but I was in a bad situation when I needed this program. So yeah, the worse situation you're in, the slower I would go. All right, so let's go to Deborah. I had my knee procedure done last week and got behind in my modules. I can't get on the ground right now or walk well. I've been doing standing exercises. Anything other exercises you could recommend? It's going to depend on what knee procedure you had, Deborah. Like, for example, if you had a knee replacement, I would say something different than if you had just a meniscectomy, which is just the removal of a little piece of your meniscus. So I definitely would recommend, if you can find a way to get on the floor, I highly recommend using that technique. So for example, if you have access to a staircase, you can sit on the top step, use the railing and just sit on the top step and then lay back. And it would be the equivalent of being on the floor, right? Because you're on a flat ground and it doesn't have the same impact on your knees. And you can kind of just scoot back and be able to do things like the back anchor connection. So get creative. And it could allow you to get down on the floor. You can use furniture, use a couch, whatever, use a massage table. You can get up onto a massage table, and that can allow you to do a lot of exercises. The goal is to be able to walk well. So whatever you can do, get an assistive device, crutches or a cane or something to be able to allow you to walk. That's a very important thing to be able to do to help just maintain or restore balance in your body, Deborah. So very important. I've personally had a knee injury where I blew out my entire left knee. It was ACL, MCL, and medial meniscus. I could have gotten surgery, but I decided to avoid it. And one of the most important things was to be able to walk symmetrically, and I needed crutches to do that for quite a while, but it allowed my body to stay in that flow, that symmetrical flow, and stay balanced. There is no such thing as getting behind in your modules, Deborah. So I need to write that in the program everywhere, that there's no such thing as getting behind. The only thing that you don't want to do is not get down on the floor or not stay committed every day. That's what you don't want to do. But if you stay on the same routine, same daily routine, same lessons, and keep doing that every day, there is no getting behind. You're doing the right thing. So work where you're at. The program is a progression. All the way through it's progressing. So you want to go to where you're at, where your body's feeling right now. And after a knee surgery, that might be module 1 or module 2 or module 3, which does involve being on your hands and knees. So if you can't kneel in a quadruped position, I would avoid module 3, but you can do module 4. And another really good thing that I would recommend if you're farther along in the program, Deborah, would be hip hinging and deadlifts. Deadlifts are a phenomenal thing for the knees, and it's like double benefit. They're very low impact on the knees. They don't require a lot of knee motion, so you can get incredible benefit without any downside. So yeah, these back and leg spasms are horrible, but I know it's from sitting, and I do try to keep moving. I was doing so great in this program. So that's okay. That's actually fantastic news, because your body's doing exactly what it should, is when you stop moving. It doesn't matter if you get surgery or whatever. It doesn't matter what the reason is. You stop moving, Your body doesn't like that. And so, the goal is to be able to get back to moving, and oftentimes an assistive device like crutches or a cane are really beneficial for getting you back out there and being able to go take a walk outside without causing more problems because you're limping. You don't want to limp. You want to use the assistive device to allow you to walk as symmetrically as possible. So that is what I have to say about that. And you made progress before, so you know you can do it again. So that psychologically is really powerful. Stein, is it okay to come up and maintain full bridge using only my abs core without the glutes? That's not even possible, but yeah, it's a great mindset to have. The abdominals cannot perform enough hip extension to get you into the bridge. They can do a tiny bit of hip extension through pelvic tilting, but other than that, it's going to be hamstrings or glutes or some of the other accessory muscles that are providing that bridge. But if you feel like it's your abs doing it, then I think that's a fantastic sign. Yeah, stay on. So whatever muscles you need to do to maintain the full bridge and stay connected, allow your body to use that. And don't try to control, I would say don't try to control which muscles you're using. Yeah, just follow the back anchor connection and the front anchor connection type rules that we have. All right. Brian, I've noticed an imbalance in my pelvis, right side forward, left side up and back. What could I focus on to correct this? So I recently put out a video on using muscle energy techniques to correct this kind of imbalance in the pelvis, Brian. And at the end of the video, I'll just spoil it for you. I strongly recommend a single leg bridge to help restore balance in your pelvis. So the side that is rotated forward would be the side that would remain down on the ground in the single leg bridge. And the side that is rotated back relative to the other side, you would have lifted up in the single leg bridge, and spend a lot of time doing that to help restore balance. And that's a really active, beneficial way to restore balance. And walking. After you do that, then go for a nice long walk. Ray, I'm 64 with retro. Oh, yep. So this is the one I kind of already answered. Any difference in the routine? No, because this program is actually designed for someone in this situation. So you just follow the recipe, Ray. Good friend Akers, Deborah. All right, so this is a good solution. So doing it on the bed. So that's an example of getting creative. A bed is not the same as mentioned, good friend. You're being such a good friend by helping Deborah out here. The bed is not the same for the push away. So anything that you can use that's more firm than a mattress is better. The floor is ideal. Top of a staircase is a way to get down on the floor. A massage table is a little more firm, or you could even put something firm on top of your bed. I don't know, like a cardboard or something that would make it a little more firm and allow you to feel that push away. But that's definitely true. Peter, I just completed module 8, was suffering from bulging maybe, L5, and want to start with more vigorous exercise. Is the elliptical machine at the gym okay to start using again? I'm not a big fan of the elliptical because it's a super heavy quad dominant machine. Makes you use your quads a lot unless you can do the machine and feel it more in your glutes, more evenly spread out through your leg muscles. But if you're feeling a burn in your quads from doing that machine, which is what I feel, I'm not a big fan of it. I would do, walking uphill or walking on an incline on the treadmill. You can get cardio from that, and incline walking. So if you live in an area where you have hills and it's not freezing cold, go outside or put the treadmill on an incline. More vigorous exercise. Start experimenting, make it gradual, make it progressive, do things in a controlled environment where you can know that know whether or not you're staying connected to your anchor triad, kind of like if you do the anchor triad marching and then you start turning it into a more dynamic exercise where you're doing a little bit of plyometric type marching, that's a good progression. And I probably one day we'll put that towards the end of the program to get people into that more vigorous type exercise. So it's a gradual progression of what you've already learned. Stein, can you list up typical pain symptoms around the hips if the cause is due to muscle imbalance? How does it feel? My pain is there, mostly on the right side. Aching, dull, sore, dull, only local pain. It's too big of a question. The muscle imbalance type pain is you're often going to feel like one particular muscle is overworked and just totally exhausted and burning and inflamed and just feel like it's just shot. And then on the opposite end of that muscle, you'll most likely feel just not much, like not a whole lot going on there. And so that's the feeling of an imbalance. People feel that in their back muscles, right? The back muscles are just chronically tight, and the abdominals, you don't feel like the same type of like tension or activation. So you want to try and balance that out, and that can happen in the hips too. Hopefully that helps. But that can result in, those muscle imbalance symptoms can result in deeper problems, deeper structures getting damaged and injured, and that is down the chain, that's downstream, and that can lead to different types of pain. So it's a cascading type situation. Ray, so vertebrae, I'm going to do my best to tell you if you're still here, Ray. Vertebrae pain is going to feel very deep and localized in the spine. So you're going to be able to go point at your spine right in the middle and go, it feels deep in there. Unless it's a nerve getting impinged, then the nerve can send symptoms really anywhere. But if you're feeling muscle pain, it's going to feel superficial. So it's the same thing with the shoulder. If you're feeling joint pain in the shoulder, it's going to feel inside that joint there. But if it's muscle pain, it might be like around the area. And so superficial, more spread out. And so it's going to be what you feel is going to help be the best indicator. Is it deep in the spine or is it superficial? All right. So Fernanda, hi, Dr. Peebles. It's hard for me to lay on the floor some days. Is there an alternative to the back anchor progression, standing up, like standing by a wall, such that you recommend? Thanks so much. So we have talked a lot about today, modifying ways to get on the floor, top of a staircase, using other furniture, doing it on the bed, trying to make your bed a little more firm. That is number one best scenario. If you still can't get on the floor, is there an alternative like back anchor progression, laying on or up against a wall? It's not ideal, but yeah, it's better than nothing for sure. So if you can anchor your back up against the wall, the back anchor, and then kind of march your legs off the floor, and you feel your abdominals engaged, that is an exercise that could be beneficial. So it's just going to be a less controlled environment. There's going to be more variables, more room for error. So you want to be really confident in what you're doing when you do that, if you were to do that. Okay, so Ellen, I've been using an SI belt, if that's the correct name, and it is helping a lot. But what is the purpose of the white sections? Sorry, I don't have a good photo. The white sections, I don't know, because I don't know. I'm not really sure what type of belt you're using, and I can't even imagine one that has white sections on it, besides the belt that is completely white. So those are all the old questions from the chat. Here's the new chat, which I've made it to the last question mark, and I'm going to try, I'm about an hour in, I'm going to try to answer some more questions here after the last question mark, but I also have the Student Hub Student of the Week to announce, and I have a prepared question to answer as well. So let's do the Student Hub Student of the Week just to break it up. We've got Michael Brandt DeMaria. If this is a male, this would be the first non-female to win Student Hub Student of the Week, I think, or maybe in a while. But congratulations, Michael. I do know a girl named Michael, so it may not be, but if it is a man or a male winning, I'm very proud of you, because we actually called the men out, the core balance training students out a couple months ago, or a month or two ago, about this. Nobody, none of you guys have won in a while or ever. So this is great news. Michael, we're recognizing you for your enthusiasm and tenacity, thinking about ways to apply CBT to everyday life and keep your inspiration for healing at the forefront of your mind. Fantastic. I am very proud of you, Michael. You get an extra month to your core balance training membership. You have to do nothing. We will add it to the back end. Congratulations, and keep up the good work, Michael. Here is our prepared question. It comes from Devana Janusik. She says, my doctor has recommended rebounding for lymphatic flow. Is rebounding good or bad, or bad idea for someone with bulging discs and degenerative disc disease? All right, so we're going to look at a picture to help answer this question. So rebounding is kind of where you're bouncing. Basically, it's bouncing. And if you are bouncing, it could be on a trampoline or it could be on the ground. It's just the idea of bouncing. It's going to help things move. It's going to help your lymphatic fluid to flow through your body. It's going to help movement is good for fluid flow. It's good for blood flow. It's good for all kinds of things. So yes, it is helpful for that. And that's not your question. Your question is it good or bad for someone with bulging discs and degenerative disc disease? So the answer to that is it depends. And the reason it depends is because it really heavily depends on what is going on arthrokinematically, or deep in your spine and the joints. So for example, if your spine looks like this, where you have uneven compression, so you can have vertebrae that look like this, where there's more even compression, or it can be even more level, like this one up here, or let's compare like this one. Bouncing on this is great. It's phenomenal. It's not going to hurt anything because the discs are designed to take that impact. But if you have a bulging disc or a degenerated disc, it's going to depend. Now, bouncing on this, it may be a little bit, of an impact because there's a spondy going on here, and there's not congruency from the vertebrae above and below, and so you're going to cause damage over here on the part that's overlapping. And this is an example more so of stenosis. You wouldn't want to bounce on that, right? Because you have a really uneven level of congruency in the joints. But if you are doing things to restore balance in your spine, and your spine looks a little bit more balanced, even if you have degenerative disc disease, you can restore the congruency in the joints through muscular balance, then I would say that rebounding may not be such a bad thing for you. And so that it's going to depend heavily on what you feel. How do you feel? And do you feel like your spine is getting better? Do you feel like your body is feeling more balanced? If so, then I would consider giving it a try. I would consider trying it at a very low level and see how your body reacts. If you feel like your spine is not in a good situation intuitively, then that would be your answer there. Probably shouldn't be bouncing on a spine that might look like this. But if it were to look like even just this one up above, that may be fine, because rebounding really is not that much impact, not compared to the repetitive trauma of something like sitting in a terrible posture for 8 hours a day for years of your life. That's much more repetitive trauma than rebounding for 5 minutes on a trampoline. So that's my answer to that. Hopefully that helps. And let's see if we can do some more chat questions. We still got people here, so I'm going to do my best. I'll go till 1:20. It's 1:13 here on the West Coast. So let's go to 1:20 and see how many I can answer. So this one comes from Nikki. And no, I already read that one. Trevor. Can massaging the lower back with a ball near or at the QL loosen things up to where a spinal traction adjustment can take place at S1, L5, thereby allowing for more extensive bridge? Oh, gosh. Okay, I have to, for this question, hopefully you're still here, Trevor, I have to take a couple steps back. So first, we want to understand that the bridge ideally involves no extension of the lumbar spine. It involves extension at the hips. Okay, so these muscles that you're talking about massaging, if you're doing the bridge the right way, will not be affected at all by doing a bridge, because we're not extending through the lumbar spine. We're not even thinking about bending or flexing or anything the lumbar spine. We're just connecting our back anchor to the floor and then using our hips, our abdominals, and our glutes to bridge up, which that extension motion, all the motion should be happening at your hip joints, both sides, and they are going into hip extension. And the higher you bridge, the more your hips are going into extension. And ideally, your lumbar spine is not even really moving. It's being stabilized by the muscles around it. So that's the step back that we have to take. And then to answer your question, I don't really recommend, Trevor, I don't recommend massaging the lower back, really. Like, especially in a weight-bearing situation, like on a trigger point massage ball or, a foam roller. I don't recommend foam rolling the lumbar spine. What I do recommend is foam rolling and developing more mobility in the thoracic spine, which is a lesson later in the program. And that is going to help those muscles. And if you can get more mobility in your thoracic spine, that's going to help those muscles to let go. Because even massaging muscles from the surface level is a surface level solution. It's only going to have a temporary effect. So what we want to do is we want to address it at a more root level. Why are they tightening up? Well, probably trying to protect, most likely. Why are they trying to protect? Well, the lumbar spine might be getting overused or damaged or getting some trauma somehow. Usually, most likely, it's repetitive trauma. How do we reduce that? Well, we get the joints, the body parts above and below the lumbar spine, which are the hips and the thoracic spine. We get them to do more, get more mobility in them. Most people with lower back pain have tight hips and a stiff thoracic spine. I'll say that again because I messed that up. Most people with lower back pain have tight hips and a stiff thoracic spine. And so what we want to do is we want to improve the mobility in the thoracic spine and the hips and stabilize the lumbar spine, provide it more support. And that is a recipe that's going to work for 80, 90, or higher % of people. So that's the way I would want you to look at it. And massaging the lumbar spine, massaging the lower back is not stabilizing it. It's mobilizing it. So that's another way to look at it is you want to mobilize thoracic and hips. Making that as clear as possible because that's really important. You don't want to loosen things up. And even traction, traction is not part of the program because traction is not helping the goal that I was just talking about. If you think about it, what is traction? Well, yeah, it's separating things, it's decompressing things, but it's not getting to the root of the problem, and it may actually be separating joints in the lumbar spine that we need to actually stabilize and stiffen up because they're too mobile already. So pulling them apart would make them more mobile. All right, Claudia, this session has been so helpful. SI joint issues seem to affect a lot of people. Perhaps in a future session, you could present something similar to help us understand it better. That's what I'm going to do. Thank you for the recommendation, Claudia. I'm going to do that. Trevor, I'm having a lot of shoulder neck pain when I breathe in deeply during the bridge. What's going on here? So shoulder and neck pain is another symptom of thoracic spine stiffness, potentially kyphosis. So that would be another indicator to me that if you improve the mobility in your thoracic spine, so that's a module 3 lesson, you can use a foam roller. You can, there's other ways to do it as well. That could help the neck and shoulder pain. And then also the bridge inherently does put pressure on the neck and shoulders because you are forcing them to go into a flexed position, and it's probably reproducing an issue that you have already. This is going to be like my guess that I feel like could be a pretty accurate guess for you. You probably have an existing issue with thoracic stiffness and kind of like a kyphotic situation where you're maybe a little bit, your shoulders and neck are experiencing a little bit of repetitive trauma from that thoracic stiffness and in a kyphosis position. And the bridge is reproducing that. It's too similar to the existing problem and putting force on it and body weight on it, forcing you into a flexed posture. So that's triggering the pain. So it's just a guess, but it's a very common thing. One of the solutions you can do for that is to bridge on an elevated surface, top of a staircase, where your feet are a little lower than your spine. You can bridge on a Swiss ball. You can bridge on a Bosu ball. You can bridge anything elevated that would just allow your spine to just be more neutral and not be forced into that curved position by the ground. Okay, it is 120. I said I would go to 120, and that's what I did. So Nikki, amazing images. Deborah, yes, I did. Fernanda, let's see if I can just bust through these. Is it expected to have a certain level of pain increased when first starting? Actually, it's not expected, but it's not too surprising because what we're doing is a brand new thing, Fernanda, that a lot of people haven't done in maybe decades. And oftentimes there's a little bit of pain associated with just having stiffness in those areas. They're very harmless. Back anchor push away is extremely harmless and you're not going to hurt yourself. But just like after being in a long car ride, when you first get out of the car, there's a little bit of pain when you first move your joints, knees, hips, whatever. You've been in the car for 8 hours and you get out and there's some stiffness pain because you're starting to move those joints. It doesn't mean getting out of the car is bad for you. It means that you need that movement, and just as that initial movement, learning in the program, learning how to get some movement in that area, it can sometimes have a little bit of stiffness pain in the beginning. Kareen just started the program a week ago, already feeling less pain. Why lying in my back is the worst position? It's kind of a big question, and it's just going to depend on the anatomy and the situation. The short answer is it's probably too similar to the postural or repetitive trauma situation that's causing your pain. So that would be the short answer. Okay, Nikki, you had spine fusion due to severe scoliosis at age 13, so T4 to L1. So interesting to see how the spine fusion works from those images. Since April now, a herniated disc. CBT has been helping. All right, thanks for sharing. Yeah, T4 to L1 is a long multi-level fusion. Archangel, your information is so helpful. Thank you for the gratitude. You're awesome, Archangel. Greg Pietrus, I wear Skechers Max Comfort sneaker. Does extra softness have any bearing on my pelvis being locked forward? I don't recommend that, Greg Pietras. I think you were the guy that asked about the beer belly last week. Maybe, maybe not. Anyway, just recalling that. I thought more about that later, if you were the one that asked about beer belly. I don't recommend soft shoes. It does not provide any more cushion for your spine. It only provides cushion that separates you further from the earth, which affects the way that your body, your neuromuscular system interacts with the ground, and it makes it less natural. And so I don't recommend cushiony shoes. It's not going to help your pelvis. It might actually hurt the position of your pelvis. And I have multiple videos out about that on the YouTube channel. Meniscus repair. All right, Deborah. So, most of your pain, Deborah, is just going to be from inflammation. And as those cuts through all those tissues heal, you should have no real restrictions. So I would, everything I said, I would back that up by saying maybe even you could do more than that. So that is all the questions. I did all the questions today, and had a little technical difficulties in the beginning of the stream, but we worked it out, and we still got people here. So thank you for being here. And yeah, the topic of today's stream was, supposed to be more about herniated discs, but what it ended up being about was all the different things that can cause sciatic type symptoms. So we talked about herniated disc, we talked about bulging disc, stenosis, facet pain, facet joint syndrome, bony growths, soft tissues, and other muscular type tissues that can press on a nerve through inflammation. We talked about all those things as possibilities for causing the symptoms of sciatica, what people call sciatica, in your hips and legs and thighs. And the reality is we can't really know with certainty which thing is causing those symptoms. And sometimes an MRI can show it. And if you do figure out what is causing those sciatic type symptoms, it may be helpful. Most of it would be helpful for a surgeon if you were going to get surgery, but it's not really going to change the solution for you, and if you're not planning to get surgery. So the solution, no matter what is the cause, is probably going to be developing more support for your spine through muscular balance and core connection in the muscles that surround your lumbar spine. And so that was the topic of today, and I hope you found it helpful. Those images were really helpful for me to just be able to visualize, especially the difference in location of the sensory nerves and the motor nerves, and why, if you have pain in your legs from a nerve compression in your spine, that it doesn't necessarily mean that you're going to get paralyzed, because the motor nerves, the nerves that control your muscles, are in a different location, and it may be that the motor nerve is not going to get compressed at all, even though you do have a nerve compression, and it's only a sensory nerve. So I find that really interesting and just comforting mentally if you do get symptoms like that. So that's it for today. Thank you all for being here. And until next time, get down on the floor and connect to your core. All right. Take care, everyone.